the pleasure to introduce Alexander Avran for the first presentation in this session, Toolbox for CTO Procedures. Dr. Avran.
Yes, thank you so much. I don't know if I am able to share my my screen actually, if I have the authorization of the organization. Okay.
Okay.
Can you see the screen?
Yes, we can see it clearly. Perfect. We owe Dr. Avran a lot for our teaching in CTO. He has been always in help, and we went to him in Nice actually for a course there for the young interventionists, and he was very keen for teaching, and I thank him for this, and thank him for his continuous support to our working group and our society. Dr. Avran.
Always, thank you so much. So I will try to be very, very clear and very educative for the toolbox in CTO, because there is something which is really mandatory. You need to have a very good nurse and a very good radiologist also. So it's very important that you involve your paramedics team in your CTO team. Secondary, what is also mandatory is to have different size of shifts. So usually we are using 6, 7, or sometimes 8 French for the CTO, depending the device we want to use and we plan to use. We need also the guiding catheter of the same size. So it's very important to have these different tools in your lab to start the CTO program. Very difficult to or 6 French sheet. Then also the other part is the device to face some complication. So it's really mandatory to have these devices in your lab before starting a CTO program. So you should have coils, cover stent, and the pericardiocentesis kit. So sometimes you have a complication and you just wonder, where is my cover stand? Or you haven't. So you need to have this and to check that you have all these devices before starting CTO. Then, everyone knows there is a lot of CTO devices. I just want to show you what is mandatory, what is useful, and what is extra for the very rich cath lab or operator. So, what is mandatory for an antegrade operator? Because you don't need the same devices if you are doing only antegrade or if you are doing antegrade retro or antegrade dissection reentry. Most of the operators are mostly antegrade operator, so you need a little bit less of devices than an operator who can actually do everything. If you are an antegrade operator, my point is you need actually a short microcatheter. So I think 2 different microcatheter is very important. One with a good profile and one with a good support. So I don't want to give you some name, all the microcatheter. I think for me it's 2 different kind of microcatheter you need if you are an antegrade operator. You need also a dual lumen microcatheter. So there is a lot in the market actually, and one is very special, and I very like it if I'm working integrately, is the recrossed microcatheter, which is a dual lumen microcatheter with 2 over-the-wire enter, and it allowed me to do a lot of parallel wiring. So for an antegrade operator, I think it's very useful to highlight the success rate. Also, because of sometimes lack of support, you need an extension of guiding catheter, mother-child system, and there is also a lot in the market, so I let you make your choice. And then we have the wire. So which wire we need for an antegrade operator? I think you need you don't need 20 different wires. You need maybe 6, 7 wires. You need a tapered wire, so to catch some microchannel if you have a tapered cap, so the fielder family, the judo family. You need some directive wire, like the Gaia family, so I think Gaia 2, Gaia 3 if you want a Gaia 1. You need some stiffer wire, because when you are in front of some hard proximal cap, you need a stiff wire to puncture the cap, so CP12 or Hornet 14. You need also some slip ring wire to manage some curve, to manage some calcification. So in that point, the Pilot 200 and the Gladius AX is very, very interesting. And you also sometimes, if you are an antegrade operator, need some knuckling wire. So Feeder XT or Pilot will be a very good device in that situation. So if you count, you need maybe 1, 2, 3, 4, 5, 6 different wire if you are an antegrade operator. I think with this kind of wire, you can do most of your antegrade cases. If you are also a retrograde operator, what do you need more? So you need a longer microcatheter. So you need a 150 microcatheter. So in that situation, you need low profile one. So you have the name, there is other in the market. And you need also some microcatheter with a good profile and a good support. And I think it's very important to have the balance of these two kinds of profile. The profile and the support are very important. For the wire, you have your antegrade wire already, but you need a little bit more different kind of wire. So for crossing the collaterals, you need cyan wire or cyan black. In difficult situation or epicardial collateral crossing, you need the SU003. And also for externalization, you need the RG3 or RG350, and for me that's all for the wire. Also, if you have in some situation an externalization of your wire in the aorta, for example in some ostial RCA situation, occlusion, the snare is very important. So the best one is the tulip one with a free port. It's easier to catch the wire. And what is the useful devices? We have seen now the mandatory one, but what is the useful devices? As some say, you can use imaging during your CTO procedure. So Ivis is, as we have seen during the live case, Ivis is very, very useful, but it's not mandatory to perform the CTO. And also, the dissection reentry devices, Crossbow and Stingray, are useful because I use it. So I can tell you it's useful, but it's not mandatory to start a CTO program. So in conclusion, to conclude, we have a lot of devices, maybe 1,000. We have every month, we have a new wires, we have a new microcatheter, we have a new extension of guiding catheter. So you can't have everything in your cath lab, but you need to start with what you really need. So if you are an integrated operator, you need, as I show you, 6, 7 wires, 1 microcatheter, 1 dual lumen microcatheter, 1 extension of guiding catheter. If you are a retrograde operator, you have seen what you need to add. And then with your experience, then maybe you can enhance your toolbox with some devices, Ivis, ADR devices. So this is my point of view. It's a very personal presentation, but I think it could be very also useful for you. Thank you so much.
Avram, this is Hazem. Thank you very much for this illustrative lecture. Can I ask additional equipments in the cath lab? Do you think the image intensifier, the biplane machine, can add something? Machine with integrated CT angiogram can add additional beneficial something to the procedure of the CTO operator?
Absolutely, but is it mandatory in your toolbox? It's useful, but it's not mandatory. So yes, I think CT is very important in some situation to know the course of the vessel in some anatomical ambiguity, but I don't use CT so I can ask CT in some cases, but it's not my my way every day's practice.
Alex, Avaran, this is Mohammed Sofi speaking to you. Thank you very much for this nice lecture. Hello, Alex. This is a tool. Your advice for this tool is to start with one over the other in case of toolbox, because you know in CTO we don't know how to use the first one. I mean, if you use to Gaia first, or to use Builder, or to use the penetration by pilot, you have to explain to the audience of the tool which one of this wire to be used first. The second, that adding to Hazem, the new machines of cath lab now, they have CTO anticipations. I mean, because the clarity of the machine is very important to use CTO, because you cannot do CTO, number one, not ad hoc, number two, not in any machine which is blurring of the vision, because you have to see it's a long procedure. It should be added, because you are not working with only machine in your hand. You are working through car. This is the machine, which is the cell. So I agree with Hazem that something needed with the machine used for the CTO, and the second for the machine should have grace, because for radiation safety, add it to your tools.
Yeah, sure. It's sure that if you have not a good machine, you can't do a CTO. And now I think all the new cath lab machine are very good, and also the radiation are less and less, and the visualization are more clear. As you said, the clear stand, the stand boost are very useful, because we are doing a lot of overlapping stand, as you said. And after, for the wire, it's depending your personal experience. If you are very confident with a Gaia, maybe you will start with the Gaia. If you are very confident with the fielder, you will start with the fielder if the proximal cap is adequate for the fielder XT. You know, the US guys are always starting with the pilot 200 because they are very confident with the pilot. So it's depending your personal feeling and your personal experience.
Okay, thank you, Avram. Thank you very much. We can go to the next presenter. Of course, my dear friend Alfredo Galassi, professor of cardiovascular medicine in Italy. He will give us a presentation about the wire-based antegrade dissecting re-entry in CTO revascularization. Of course, we need to thank Professor Galassi for what he did for our patients, our young fellows. He did a lot for us. Thank you again, Freddy. Thank you very much.
Dr. Galassi says to me almost that he attends more than me the Egyptian meetings. He always jokes about that. And it's true, really.
Thanks a lot to all of you. I hope you can hear me well.
Yeah.
Okay. So it's really a great pleasure to be among you because I feel really at home with you. I have really my best friends, Nazim Kamis and Abel El Trivi, Khalid Shokri. And also I would like to thank Amr Ladidi and Sam Emil for this kind of invitation to be there at this Cairo CTO meeting. And I really appreciate the word of Azim because for me, was really a great work what we did together with all of you in Egypt. And I really think that Egypt grow in this CTO revascularization more than other countries around the globe. And I think that Avram also is confirming this, and probably because you have a lot of disease, probably because we are really, and you're working a lot, but I should really say that Egypt is growing really a lot in experience, and I think it's really for me a great pleasure to share with you these slides. So I hope now that you have got my presentation. Yes, here it is. I hope you can see it. 1 minute. Let me see. Okay. Are you okay? Can you see my presentation?
Yeah.
Okay. So basically, I'm discussing with you the issue of wire-based ADR and CTO revascularization. As you know, ADR is quite a real important topic nowadays, and there are issues regarding the issue of either doing by wire or doing by devices. So this is our. Can you hear me well?
Yeah, we can hear.
Can you see my slide?
Yes, we can see and hear you well.
Okay. Okay, so this is my first slide regarding EUR intervention. We published this in 2019, and this was basically the consensus document from EuroCTO Lab. And as you can see, there is quite a big of importance in this ADR, either by dedicated device system or by wire-based ADR or other technique that can be called last, mini-star, and so on. And also the concept of investment procedure, basically to do a star technique plus POBA, and then probably the further standing in a second session. After that, we have been facing many consensus, and I will deal about that. But let me say, first of all, what is about the issue of ADR. First of all, we realize that among expert operators, ADR is more and more used in more complex regions. You can see here the recharge registry, where basically GCTO less than 1 is used ADR only in 20%, 10%, yes, less than 20% of the cases, while in GCTO more than 2, we can reach almost 29% of the cases. So you can see that the use of ADR is growing with the complexity of GCTO. And also in this UK average CTO registry, where basically you can see that ADR is growing with a growing of the complexity. And you can see here that even more, 3 and 4 and 5, ADR is more and more used among operators. Also in EuroCTO Club, we face the same issue. More and more the CTO score is growing, more we realize that we are using ADR. And this is, as you can see here, is almost 40% in the more complex lesions. So basically, what are the complex lesions that we are dealing with this ADR technique? Well, first of all, is long CTO without retrograde option. This is one of the most important issues because, as you know, retrograde option now is 30% of all approaches in CTO, and nowadays is part of the strategies. But again, we can have cases where retrograde option is not available. We don't have engagement of collateral, we have a failure of reverse card or no externalization. So probably the situation with no retrograde option is one of the issues. Secondly, usually when we have a preferably good landing zone and rather proximal CTO location, and this is important for the re-entry. This is another issue when the lesions are very calcified and tortuous, and also when Ivis technique or device-based ADR are not feasible. This is something that is also due to sometimes constraint of money issue, because you know this device-based ADR sometimes is also very costly. And I would say that probably the ADR technique is probably at this stage used as mainly as a bailout technique. So this is the global chronic total occlusion crossing algorithm, which has been recently published. And as you can see here, we are all our expertise inside this global. And I would like to focus on table 1, where basically, as you can see, as a sixth issue under grade 1 strategies, including both a device or ADR, we are facing the issue that all consensus documents from Ivis, Asia, Europe, CTO, China, Japan are basically preferring ADR for very complex lesion, longer lesion, ambiguous CTO course, tortuous CTO segment, any classification, diffuse distal disease, or when you have a parallel wiring failure, or sometimes as a first line strategy, length is more than 20 millimeters. So you can see that we are all agreeing that that end-to-end wire strategy is a technique that we must use and we must experience. As we started when we retrograde approach, now is the time to teach ADR. Now, what is new in the last few years? We have better understanding of subinterstitial vessel trauma and how to avoid subinterstitial hematoma. We have more integrated wire escalation plus or minus ADR than ADR right away, because we have more dedicated microcatheters, low profile, more soft polymeric wires. So we really need to go more into the CTO body and making the re-entry inside the body rather than to start the dissect proximal to the lesion. Also, we understood that there are, because of that, less number of acute complications and better long-term outcomes. This is one of my first study when we used a mini-stars below strategy. We understood that when all other strategies were failure, mini-star was working pretty well with the basically very small number of complications, and also with, of course, the exceeded time, procedural time, proscopy time in contrast load, but also in considering the fact that we were using a lot of conventional technique for a lot of time, sometimes also reducing the time of this of the fluoroscopy, procedural contrast load. Also, we realized that this is something that comes from the UK IBCTO registry, that basically ADR is not complicating the procedure, except from some perforation that can happen. But I would say that probably this is due mainly to the heavy polymeric wire, but the use of soft polymeric wire is much less. And also, I would like to show you now for the first time worldwide this study that is going to be submitted soon to JAT intervention which is basically my experience with ADR. And as you can see, among 1,207 lesions, we have quite a reasonable number of ADR wire-based or device-based. Device-based very little, so we concentrate on the wire-based, and mainly by the soft polymeric single wire, or by step-up, step-down technique. And what is interesting in this study that, again, the confirmation that underground wiring is decreasing with increasing of the GCTO, otherwise more or less stable, probably would like to say that is increasing probably, but almost stable, but ADR is definitely increasing in a more complex lesions. And also what is interesting in this study is the technical success. It is quite high despite the difficulty of the lesion and the technique that is more or less with underground wiring alone is almost 90%, with parallel wire technique is 90%, and with this ADR technique is reaching almost 85% in a very complex lesion setup of patients. And this is very important to say that some of them were basically done only by single polymeric wire and by soft single polymeric wire, and by some other in another group by step-up, step-down technique. In going back in the previous years, we understood that this technique to re-entry is working, and is working mainly according to the when we are doing this technique and we realize that TIMI3 flow is obtained at the end of the procedure, this will achieve a very good long-term follow-up. This is also being shown by Carlino some years later, which showed that final TIMI flow 3 in this ADR and second generation drug descent are the most interesting issue of this technique. And now I would like to show you some of the cases to make the presentation shorter, which are basically cases that show clearly what is possible to do with a soft polymeric wire, as you can see in a small microcatheter, small profile microcatheter. So cheap technology, effective technology, which by the bending and the re-entry is basically producing, of course, a longer dissection than expected, but in a very short time of period, and also but reduced device, dedicated device. This is the need to implant more length stent, but this is of course something which is interesting. This is a case of follow-up, 9 months follow-up. As you can see, it's fantastic, the result. Also another case with long CTO with a lot of bridge collaterals, and once again difficult retrograde approach, as you can see, very, very curvy. And again, after dissection in the end, you can see here, then you have in this case a very long, some dissection in the PD, not much, but also a very long dissected segment, which is almost the proximal mid part. And it's interesting that even if we reconstructed the whole vessel, in the follow-up after 12 months, it shows a focal restenosis. So this is something very important. In this case of antegrade dissection re-entry, follow-up, antibiotic follow-up is a must and should be done in the proper way in order to fix this focal restenosis. That you can also see some additional flap of dissection re-entry, but this is not limiting flow. And then this is the final result after the stenting of this area. And now I would like to show you what we call the first stenting, if I have some more minutes. This is a case that I did lively in Toulouse, 2018. Very difficult, cumbersome collateral circulation. We tried all our best. It was a very long procedure. It was live cases, so everybody was facing about retrograde option. I was really having a lot of hard time, but unfortunately, because of this small vessel and collaterals, I was always going some marginal branch, never in the right one. So then at the end, I decided to go in bailout technique in antegrade dissection re-entry. I made my usual strategy to dissect first with a strong stiff wire, and then after I create some space by stiff wire, I put my soft wire and I re-enter in a more distal part. As you can see, this patient was really bad, and we had to basically, we all convinced ourselves to stent only the proximal part, leaving the rest to healing. And in fact, we implant only some ballooning dilation in the distal part, and then after stenting of the proximal area, we left all this dissected flow. And this is interesting because this was the final result. Then we end up with a follow-up of 2 months, and as you can see, the vessel is definitely needs some more stenting. Also, the approach was again dissection re-entry, and then after additional proximal stenting and distal stenting, we were able. We were able to have quite a good satisfactory result. So this is something that can be shown also with the first stenting. The first stenting after subintimal plaque modification is a safe and effective strategy to contend with complex CTO lesion when other techniques are probably high risk of a failure. You saw that this case was really a terrible case because it was really bad for peripheral vessel. Now, my final 4 slides regarding this new AFR technique, which I think may be a new revolution of the antegrade dissection re-entry by simple device, cheap device, and probably effective device. This is the balloon. The balloon covers a standard RX wire, and then we have a second wire which enters from OTW entry. The principle is that you create some dissection proximally or within the body of the CTO, and then you are able, after advancing this device that sometimes needs some preparation of the vessel, and in this regards, this balloon is going quite easily, but sometimes you have to prepare. Then inflating the balloon, the tearing of the vessel and the retracting of the balloon permits to the wire to re-enter into this tearing of the intima and making the revitalization probably easier. This is something that is a feeling, but it's not only a feeling, it is making true. We did a multi-center experience. I'm very happy that there is also Khaldun Ashwad with us among the moderator, that he was part of this study. We did 41 cases, sometime as first-line strategy, sometime after failing another ADR technique, sometime after failing retrograde approach. And I will show you now one of the case just to show you, I mean, what is the issue. This is a very difficult case with the difficult retrograde approach, a very not clear stump antegrade. So we go with the dissection mode by microcatheter and stiff wire. Then after penetration, we try to create more space by Corsair and soft polymeric wires. Then we create some more space by small profile balloon. This lesion was very calcified. As you can see, there was also anthers left, so a lot of pressure. This can you feel? This is something you can feel when you do a live cases. And then after a lot of opening of the proximal CTO body, we are able to advance this dual guidewire balloon. And as you can see, here is the inflation and the preparation with the second wire. And here, lively, you can see that the wire, after the deflating of the balloon, is looking for the fenestration. Fenestration is not something easy. It is performed by soft polymeric wires. You don't need to have a very stiff polymeric wire, very soft. But you have to work a little bit to try to look for that. And you can see that it is almost there. Unfortunately, this wire enters the true lumen, then exit the true lumen, and then re-enter the true lumen after that curve. And this is something that usually happens with this fenestration. So you have tearing that makes the second wire to re-enter, and sometimes you need to fight a little bit to re-enter. But as you can see here, the soft polymeric wires enter the distal through lumen, and this is confirmed by the injection from the retrograde. And then you basically have the final results, which show you that reconstruction is performed. Sorry, I'll try to see if it works. I don't know why it doesn't want to work, anyhow. Anyhow, this was a very good result. As you can see here, the stent was all in the proximal and mid part, and then the distality was really very good. I don't know why. Let me see if I can.
You have 2 minutes, Dr. Galassi, okay?
Okay, anyhow, the result was was excellent actually. I was not able to show you. So, final slide is that wide-based ADR may be a very important and preferably used as a technique that can be used preferably as bailout. What is called mini-star ADR may be done by a single lumen microcut and soft polymeric wire, so very cheap technology. It is always better to assess first the penetration by stiff wire followed by push of a soft polymeric wire. And as you can see, sometimes you need a medium polymeric wire. If a big loop develops, this is an unfavorable sign, and probably it's better not to keep advancing your micros and to probably stop your procedure. Regarding the stenting, always better to avoid, if possible, long stent segments. Consider the first stenting, and I'll show you a case for that. In long dissected segment, preferably use dual lumen catheter to create some side branch, and also sometimes needed Ivis assessment to secure bifurcation. For the follow-up, remember always to consider that when we have TIMI3, less than TIMI3, the unfavorable outcome is there, while if it's TIMI3 or more, if it's TIMI3 is obtained, the outcome will be very good. And also in this case, you can also basically use also non-invasive imaging technique. But if you have an TIMI less than 3, you should also re-angio the patient. Also important to plan anyway a 6-9 months angiography follow-up in case of long stenting segment. And this is especially if there is a big dissection long segment, as you saw in my case, because focal restenosis may occur. Thank you very much for your kind attention.
Thank you, Galassi, for the excellent presentation. Actually, I think we needed more time to understand this technique, and maybe in a live case or something, we can really understand what's going on and the steps approach. It's a very interesting approach, and I think it will make like a cheaper way to cross anti-grade. I hope we will see more of this technique and we will understand it more. As a matter of fact, I didn't actually catch the exact details of it, and we need to do that in another session, maybe in a live case or something. So thank you very much for this, and I think because of time, we'll move on the schedule. Thank you, Kalis.
Thanks, Dr. Afram, for the first lecture, which was very basic and very illustrative. It is my pleasure to invite Dr. Afram to speak about the different anti-grade techniques.
Is it good for you? Can you see the screen?
We can see you, but not the screen. We can see you, not the screen. So it starts
slides better.
Yeah, it's good to see you anyway. Yeah, we can see the screen now. Yeah, we can see the screen.
Okay, good. So, so I want to show you today the different integrated approach strategy. So it's very important. So most our CTO are perform integrated. Why? Because the wire are improving every day. So our success rate integratedly is also improving. And every day. So in my experience,
we have a problem with the transmission with Dr. Avran, I think, because of... you are still with us, Dr. Khaldoun and Dr. Galassi, or... محمد صبحي أنت معانا؟
أيوة معك.
Okay, you are back now, Dr. Avran.
Okay. As I said, there is different way for the integrated approach. You have the integrated wiring. I think there is the parallel wiring, and there is the integrated dissection reentry. Alfredo show us some kind of low-cost dissection reentry, and but there is other kind of dissection reentry. But the best is to start with the integrated wiring. So a lot of people ask me how to choose my first wire, and my answer is always the same. It's depending the proximal cap. If the proximal cap is tapered, it's better to start with a soft polymeric tapered wire, just to try to catch a microchannel, and sometimes you have a very good performance of this kind of wire. If your proximal cap is blunt and seems to be a little bit calcified, my first choice of integrated wiring is the Gaia family, the Pilot 200, and if I really need a stiffer wire, it will be the CP12 or Net 40. If I have no stump, then I will maybe use Ivis to help me for an Ivis guiding puncture, or I will do a base technique just to move on the proximal cap and to get inside the subintimal space before my ambiguous proximal cap. And if it's not possible, then it will be another chapter. It will be the retrograde chapter. But today, we are only speaking of integrated strategy. So here, for example, this is the way I want to catch a microchannel with the Fielder XT, and then the drilling technique with my hand to move the Fielder and inside the microchannel, and you can see that the Fielder is advancing and catch the distal true lumen. So this is the secondary point is how to use the Gaia family. So you see, it's not really the same technique. It just torque, deflect the wire, and torque and straight it just to cross the segment. So it's a more directive wire than the Feeder XT. And you can see the distal cap, and then we straight the wire, and the wire fall inside the true lumen. And then you have a very calcified proximal cap, so I want to puncture. So here it's very different. I just find the resistance of the proximal cap with my stiff wire, and then just with my left hand maintain the pressure, and with my right hand rotate my wire slowly first, and then maybe if I'm not able to cross, I will rotate a little bit faster, and then I am able to puncture the proximal cap. And after puncturing the proximal cap, you can step down with some softer wire to navigate inside your CTO bodies. The secondary approach after the wiring, the wire escalation also, so anti-grade wire escalation or anti-grade wire desescalation, depending what you want to do, is the parallel wire technique. This technique is still very important. I know that some operators are, they don't like this technique, and some of them just tell me that they never done this technique again, but I'm still working with this technique, and my success are very, very high with this parallel wire technique. So the old fashion of the parallel wire technique is to use one microcatheter. So you can see this circumclusion. So I was there with Gaia third and a microcatheter. My Gaia is puncturing the right proximal cap, I thought, and then the feeder XT is outside the true lumen. And with this old technique, what I will do is to remove my microcatheter by trapping my feeder, my Gaia here, and let my Gaia in place. And you can see clearly in that projection that the true lumen is a little bit higher to my Gaia. So I just trap my microcatheter, let in place the Gaia, and come back with my same microcatheter and another wire. This is the point, and you have seen that the true lumen is a little bit upper than the first wire, so my secondary Gaia is moving inside, I think, the true lumen. And then we check, and you can see clearly that my secondary wire was able to catch the true lumen with the help of my first wire. Why? Because my first wire just showed me where is the course of the vessel, and also straight a little bit the vessel. And with this, it's easier to puncture the true lumen with your secondary wire. So this is the final result. And now with new devices, we can really facilitate the parallel wiring technique. I'm really now a great user of this new device named Recross. So as I show you already in my previous lecture, the point is with this kind of devices, I'm now able to do integratedly CTO, which are a little bit longer than what I did before, with a higher percentage of success, higher rates of success. And the point is, I use the Recross as my first microcatheter integratedly now, and I'm working with my CTO wire. If my first wire is in the true lumen, then the Recross can be used as a microcatheter. If my first wire is subintimal, Then I let in place my wire and I'm ready for the parallel wire technique. I just tell you why. This is a recross. Recross is a dual lumen microcatheter, and the difference between this one and all the other one dual lumen microcatheter is that there is not a monorail part and an over-the-wire part. There is only two over-the-wire parts. The white one is, the wire is going at the distal tip, and also you are able to go in a lateral one. The blue one, the wire is going to a lateral one, but in the opposite direction of your white one. So it means that you are able to work with two wires and to exchange your wire when you want. So it's a freedom feeling, which is very interesting. So just a small video to show you. So there is some membrane inside. So just place the two enter of the microcatheter. The blue one, you insert your wire and will exit in the lateral part. So as the other dual lumen microcatheter. And the white one, you can exit distally or also laterally. So this is a distal. If you want to go lateral, you just pull back a little bit your wire. Turn it a little bit and just push it, and then you are also in the lateral. So this kind of exit is maybe useful for some re-entry technique, but in fact, what I want to show you is the point that it's easier to do parallel wiring like this. So for example, you have this kind of lesion. So I use a recross as my microcatheter in first intention. So in the blue port, I will just anchor a cyan blue in the marginal branch, and with the distal one, I puncture the CTO body with a Gaia wire. Then my Gaia is subintimal, so I just remove my cyan blue, advance a little bit my recross, and use the blue enter with a secondary Gaia, and do parallel wiring without removing the microcatheter and coming back. So it might be everything easier, and it's faster also. And then just succeed the parallel wire. So just to finish, we have also integrate strategy is also sometimes a ADR strategy. So you have this kind of lesion. There is some anatomical ambiguity, some curvy part in the RCA, as you can appreciate. Here, unfortunately, any wire was able to cross in the true lumen. Every wire were outside. So we just knuckle to manage this curvy part. and then advance. So check retrogradely. So our microcatheter is very close to the lumen. So advance a stingray balloon, and we know that the true lumen is on the right side. So stick with Hornet 14. The Hornet seems to be inside and outside. So we exchange the stiff wire for more slippering wire. This is a Pilot 200, and then exiting the same way and just manage the curvy part. We check, and then we are in, just stent, and this is the final result. So just to show you the stingray balloon where the wire is exiting, and just to show you that there is a lot of integrate strategy. We know all the integrate wiring escalation. We know all the parallel wiring. I think there is a new way for this parallel wiring, very, very easy. And also, if everything failed, you can have the integrate dissection technique, as Dr. Galassi showed you, and also with some specific devices like the Stingray. Thank you so much, and hope to see you soon, everyone in Egypt. We miss you.
Thank you, Avran. I'm Amr Al-Hadidi. How are you? I'm very happy to see these great lectures that you gave us today. I would like to ask you about, I know that Khaldun will not agree on what I say now, because he likes Stingray and and so he's an expert, and I know also you are expert, Avran. So what about the recross use in this scenario? How do you think that it could help instead of the Stingray balloon, and what do you think?
So what I think that I'm still preferring the Stingray, because I tried maybe several times, and with the recross it's not very ideal, because you don't know where you are in the space and in which projection is the best projection to direct your puncturing wire. So I tried, I failed. So I just go back to my Stingray, and with the Stingray I succeed. So actually I prefer a little bit the Stingray for the re-entry than the recross. But the recross for the parallel wiring is very, very useful.
Okay.
Alex, this is Mohammed Sobhi again. Thank you very much. My question to you, adding to Amr, is I know that Stingray, you compare it with the AFR. It's not compared with the recross. Am I right? Because AFR, somewhat like a penetration, which more or less like what you have a Stingray. But the difference with recross, as I understand from you, that it has two ways. One at the anchor wire, and then you change it to be parallel wire. It's not only parallel wire. It adds you one wire to go in one direction, and then you make the blue or the white to work in the parallel wire. It's completely different from the Stingray. Am I right? Or can you explain that it's different? Because we have three ways now.
Okay. The recross is a dual lumen microcatheter. So you can manage your both sides to anchor, to puncture, to do parallel wiring, and also to manage bifurcation. Okay, this is the first life of the recross. Then the guys from the recross said, "Oh, we have two different opposite exit. Maybe we can go to fight with the Stingray." But I really prefer the Stingray actually. I don't know if Cal has some experience with re-entry with the recross. I don't know if it's available in US actually.
No, I don't. I haven't seen it in the US. I've seen it in Europe. I have not really used it, so I can't really talk about it. But we use a Stingray in the ADR is now, with the advent of Gaia Next 1, 2, and 3, we are actually more successful anti-grade wire escalation. And when you end up in the subintimal space, we are basically uses Stingray most of the time, and retrograde, depend on your practice. And with the current use of basically subintimal plaque modification, we see that sometimes safer than keep trying, and we bring the patient back. The CTO PCI should be multi-stage procedure. Like, why do we have to achieve complete revascularization and stenting from the first time? So unfortunately, I never seen the multi-cross in the lab. I've seen it in the table in France, actually, during multi-level CTO.
I think that this recross may be used more and more as a RX balloon, RX dual lumen balloon. So basically, RX dual lumen microcatheter. So basically, as a device to use parallel wire technique. I agree with the comments done before by Professor Mohamed Sobi that basically probably this may be used more in the strategy of parallel wire technique rather than re-entry by soft polymeric wires. And in that regards, the probably dual guide wire balloon is maybe more dedicated for the re-entry in the fenestration technique. But definitely the recross may be used for parallel wire technique and may be a good alternative to the dual guide wire RX classical device, microcatheter.
Okay. Thank you, Avram, for this great talk. Now we'll move, because of time, we'll move to Dr. Khaldoun Al-Aswad from USA. Dr. Khaldoun. Dr. Khaldoun is Director of Cardiac Estrogen Lab at Henry Ford Hospital, and he's one of the pioneering CTO intervention. And they always do very complex cases CTO on live transmission. So very happy to have with us. And also I'd like to say hello for Dr. Alicio Lamana is with us, and Dr. Galassi. How are you? Okay.
Thank you so much, Amr, to invite me. It's really an honor and a point of pride for me to see, as you know, I'm Arab American, and Egypt is kind of leading the world now in CTO PCI, and that's thanks to your guys and your effort, Dr. Subhi Atrabi and everybody in the panel, and I'm very proud of this because it's just a point of pride for me. Again, it's an honor, and hopefully we'll kind of be in person next time I see you guys at TCT. So my direction today from Amr to speak about Ivis guided CTO PCI, and we already kind of a lot of speakers before me kind of alluded to that. Just as a disclaimer, I use about 100% of the time, every time I do CTO, I use Ivis. And in my lab, we use Ivis in 90% of the time in any PCI. So CTO 100%, any PCI 90%. So how do I use the Ivis in the CTO? Ivis can provide a lot of information and decreases contrast. So we start with the proximal cab. Even when you do dissection and re-entry, any dissection, either retrograde, antegrade, or ADR, and the most important thing is actually that's the most commonly used is the stent optimization. And there are multiple sets of data shows that if the lesion's more complex, the Ivis becomes more valuable. And our Chinese colleagues show us in all comers, Ivis is still valuable. So Ivis in a proximal cab. Ivis can tell you where is the cab and what is the cab and what to do about the cab. So this is like a Cirque CTO, and if you tell, I don't know where the cab is, really, really hard. So basically, this is how you do it, and you put where you think the cider branch, and if you have a cider branch, you always have a cider branch, and you kind of very lucky. So you put the Ivis in the cider branch, and right there, it shows you exactly where the cab. So once you look at the cab, you can decide what kind of wire you use. This is a cab very, very heavily calcified? Do you need to Confianza Pro 12 or a Hornet 14? Or this is a cab you can actually go with a Gaia 2nd or Gaia 3rd or Gaia 1st. And sometimes you discover you can actually use a polymer jacketed wire. And after you do that, basically the Ivis can confirm to you that you are in the cab. So this is basically an LED flush CTO. Nobody can tell me where the cab just looking at this. So here, if you notice, we are looking at the cab, and basically took a Gaia 3rd and I reshaped a little bit of the Gaia 3rd, left the Ivis there, and you can see the wire right there. Basically, it's your CTO. You wire in it, so you can advance the microcatheter. And of course, to advance the Ivis unfortunately bulky. Sometimes you need to advance it into, you need to treat the vessel. And here it's a kind of live one of my cases. This is basically, I just want to go back one slide in here, and I want to show you, this is how, this is basically a CTO of the left circumflex. And you look at the distal branches here. So Ivis guided, there was not much really retrograde options. Even ADR is not good because it's a bifurcation at the distal cab. And when you look here at the right side of the screen, I can see the wire right in the cab. So I was able to advance a microcatheter, and you basically you downgrade the wire, and the wire basically went smooth sailing, and we have huge circ, huge OMs. We were able to preserve both branches. And after you cross, actually the Ivis will tell you where is the other branch, so you can wire it. You don't have to inject antegrade, especially if you dissect it. So Ivis role in the dissection reentry is very important. You could identify what is your wire in the subintimal space versus a true lumen, and regardless of what dissection reentry, if you go in antegrade or retrograde. And if you go and trying to do reverse cart and you're having a hard time connecting, if you put an Ivis in the antegrade wire, that will actually tell you which is the closest point between the two wires, so you can actually puncture at that point. And also, if you are doing really getting close to the left main, ensure safety. So this is an LAD. Actually, we end up in a subintimal space. We tried antegrade dissection reentry several times. And then I'm coming back with a second wire, and my Ivis in the first wire, clearly in the subintimal space, and now I notice that my other wire is actually in the true lumen, and you can actually see it from the beginning. This is the true lumen from 6 o'clock to 11 o'clock on the left side, and you can see the other wire in it. So basically, serendipity, this is by luck. My other wire was actually in true lumen that finished my procedure. Ivis also determine the wire position when you cannot inject. When you do an antegrade dissection reentry, a lot of time you lose retrograde visualization, and you cannot inject antegrade because you basically expand your dissection and you cause a lot of hematoma. This is an RCA here with basically very diffuse distal targets. It's not good for anything. You basically got a dissection reentry. We used a Mongo wire and dissected into the vessel, and then we used the Ivis guidance to wire the vessel. But I wanted to see what surprise I got in here. Like, this is for Fredo Galassi's talk. If you notice, we are basically doing the Ivis from the PDA. I noticed that we actually here, we have a dissection all the way in the RCA, but there is a small landing zone right before. So to my surprise, the wire entered right before the bifurcation. I wasn't planning on stenting it, and now I stented the RCA up to that bifurcation, and I was able, and the only way to get that information is by Ivis. When you're doing retrograde, especially near the left main coronary artery, I always put Ivis in the left main over the side branch, which is circ, or if you're doing circ or LAD, I always put an Ivis there. The Ivis could help you puncture back, but the Ivis is more important to help you connect and help you protect the left main. This Ivis here on the left side of the screen, sorry, I'm going to go back a little bit. This is actually the hematoma in the left main. I knew my wire in the and the hematoma extending to the left main. I changed its strategy immediately, and I was able to make sure that the dissection does not extend retrograde into the left main. So Ivis help avoid extending, and if you get a left main dissection, the only way to save the situation is by Ivis. However, the most important thing is Ivis is very, very, very important in actually helps you avoid contrast all along. This is a patient of mine. She actually had this SVG to the circ, failing several times, and it failed. And I brought her back to open it, and the first injection, we injected contrast, and the patient literally had to push with both hands to be able to push air inside her lungs. She has severe anaphylactic shock. We basically put an ECMO on her because I didn't know why she crashed, but we took the ECMO at the end, and we asked the allergist. The allergist told us you give her this prednisone, about 60 milligrams 3 times, like you give her Benadryl, 50 milligrams 3 times, and you give her also Tagamet. So we did all that. We brought her back to the cath lab, and the minute I injected the first contrast, she actually repeated the same exact thing happened the first time, severe anaphylactic shock. So what to do in this patient? She's still symptomatic. We brought her back, and this time I used gadolinium to help guide me a little bit, but this is the whole vessel was opened with Ivis guidance. So this is how we did it. This is the circ CTO. This SVG, by the way, this is an old picture of the SVG. I never could take a picture of the SVG. The SVG was significantly diseased by Ivis. We went down the SVG back in the circ, and this is here the knuckle retrograde into the circ. And if you notice here, you can actually look here. I see the tip of the knuckle. I wired over this small OM, and you can see here at 6 o'clock and 4 o'clock, you can see the tip of the knuckle. So we use Ivis to basically see that the wire is in the true lumen. And if you notice here, the wire is actually subintimal space. Then I'm pulling back the Ivis, and now the wire in the true lumen. We directed the wire into the integrated guide, and then we use in here after ballooning. I'm using the Ivis to decide stenting. And this is the final picture. This is actually gadolinium injection. Gadolinium does not give you any better picture than this. And guess what? This patient does not have angina anymore. So we were able to use Ivis to perform the entire procedure with no contrast, no iodinated contrast. I used like a 10 cc of gadolinium. The problem with gadolinium, you only can inject up to 20 cc in the best patient, 0.03 per kg. And you dilute it, and so it's not like gadolinium can replace contrast. You only have 20 cc to use, so it's really very hard. So Ivis determine whether to stent or not to stent, as we said before. This is here the Ivis cannitillinium. This is the subintimal. We are in the subintimal. The true lumen is here, so we decided not to stent. Ivis data, there is a lot of data. I'm not going to go over it. But in a CTO PCI, the Ivis showed significant improvement in outcome of the procedure, cumulative 12 months intention to treat on per protocol. And this is cardiac death MI, target vessel revascularization. This is by Kim et al., published in 2015. Significant improvement in the progress registry and other. We showed that Ivis decreased stent thrombosis, MI, target lesion revascularization, and in the progress, 36% of the cases used Ivis, equivalent success in higher JCTO score. So the Ivis improve outcome in those patients. In summary, Ivis resolves proximal cap ambiguity and guide proximal cap crossing. Ivis is helpful during ADR and CART procedure, decide entry, re-entry and segment, decide wire course, and Ivis can replace contrast for zero or minimum contrast, as actually ZLE and Dimitri Karampoliadis showed us. And if you have any question, please email me or call me. Thank you so much for inviting me to give this talk. It's always an honor to meet you guys.
Okay. Thank you for this great demonstration for how to use Ivis. Definitely, Ivis is one important tool for CTO procedures, and always you are using I know in most of your cases are using Ivis. I want to explain, especially in reverse cut. So when you have a wire in retrograde and wire antigrade, so the best option, do you think, was subintimal retrograde, subintimal? I would like to show the Ivis role in this scenario. If the wire is retrograde wire and in relation to antigrade wire in reverse cut using Ivis. Do you think that the wire, the subintimal wire in retrograde meeting subintimal in antigrade? What do you think is the role of Ivis now? It's very important to assess where is the retrograde wire.
Okay, so there is a point I did not actually mention in my talk. So the problem with failing to connect the wires, regardless if you're subintimal or intimal, or like we all know, if you have a true lumen retrograde and subintimal antigrade, that the highest failure rate of reverse cart, and the reverse is less. And the best option is to actually have both antigrade and retrograde in the subintimal. So the role of Ivis here is to reassure the operator that you need to use a bigger balloon. A lot of times people use 2 millimeter, then 2.5, then 3 millimeter balloon, and the vessel is 5.0. And unless you use big enough balloon, you're not going to be able to make the connection. So the number one role of Ivis in this situation is to reassure the operator that it's okay to use 4.5 or 5 millimeter balloon to make the connection. Now, if that failed, the second thing is role of Ivis is actually to show you where the wires are closest to each other. Once the wires are closest to each other, I will take I will measure with the distance, and I will take a Confianza Pro 12, and I actually bend exactly how big is the vessel. I make the bend with the Confianza and a puncture with it to be able to connect. So it is more for safety and reassurance of the operator and to make the procedure success. But after that, the most important rule with an antigrade dissection reentry, reverse cart, as you know, sometimes we end up with a long dissected segment. So if you have a long dissected segment from the Proctor CTO trial, it was actually increased of lumen loss or restenosis, about 13%. So in Ivis could help you actually shorten that segment, and second, optimize. The most important thing is to optimize the stent with this to make sure that you put big enough stent to decrease the chance of late lumen loss.
Okay. Khaldun, I think, thank you very much for this nice, as Mohammed Safi is speaking to. You know, Khaldun is now the head of the Henry Ford Institute, where I was in 1984, just as a fellow, started my career in PTCA with Kaja at that time. It's 38 years ago. Khaldun, regarding the Ivis, it's not should be a routine in CTO. So I'll give you my philosophy. It should be used in zero contract patient CTO. This is number one. Number two, if you have an ostial flush CTO, I mean, if you don't know the cap, but in the ostial right or ostial left, it's impossible to cross it without knowing where the cap. This is the two main indication. Otherwise, this is adding value to those used to have Ivis in every case, because you know in our country we don't use Ivis routinely, but we do it in special cases. Regarding stent optimization, yes, but we can make it without stent boost. But ostial lesion and zero contrast, is the main two indication, and then you can add what do you think about these two indications?
So absolutely. So the thing about it, we have it available here in the U.S. and it does not. I know you actually can know the size of the vessel by the knuckle, right? So before I start using Ivis more frequently, the knuckle always told me how big is the adventitia to adventitia, and I will use big enough stents. I use the Ivis mostly for stent optimization, but for the questions you elegantly said, like when you have ambiguous proximal cab, a flush occlusion of the CTO in special situation, yes, you need Ivis. I think you can survive without an Ivis if you don't have access to it. You can actually do very excellent job. We have data nowadays that Ivis is actually added for a long term. Even 1 year outcome has improved in patients who received Ivis, and that's actually been corroborated by a UK study from the BASIS registry, and that's by all comers, and corroborated by the Chinese and multiple data sets. So if you have the luxury to access Ivis, I will use it. But if you don't, you still can do a good job, and there are other clues and to tell you how big is the vessel and how to land your stents. Absolutely, especially with experience like yours, Dr. Subhi, it should be no problem.
Thank you, Khaldun, for this great presentation. And also, I'd like to thank all the chairpersons and the speakers of this session. And now we need to